I would like to thank the organizer for the kind invitation to talk to you today about the clinical indication for electroencephalography monitoring in neurocritically ill patients. My name is Lara Prisco, and I'm a consultant anesthetist and intensivist in Oxford in the United Kingdom. In the last 10 years, there has been an increased interest in the electroencephalography monitoring in critically ill patients, and this has led to the development of structured guidelines suggesting clinical indications, but also technical standards and the terminology for both adults and children admitted to intensive care. Often the aim of such standardization has been driven by the need to harmonize collaborative clinical research in critical care. Nonetheless, many institutions, often academic tertiary centers, have adopted and adapted the American Clinical Neurophysiology Society guidelines in the setup of critical care electroencephalography services. And to this end, North America has preceded by far Europe and other continents in the development and integration of these services in neurocritical care units. Nonetheless, there has been noteworthy examples of European sites who have been recording continuous EEG in neurocritically ill patients for several years, and many more are joining. We have followed the same approach in our institution in Oxford by establishing a mixed service between the neurophysiology and the neurocritical care department. And the first step has been the development of an internal protocol to prioritize our resources to the patients who need electroencephalography monitoring the most. Our top priority are patients with suspected or confirmed status epilepticus, refractory and super-refractory status epilepticus. This is because these are the patients at the highest risk of having ongoing subclinical or clinical seizures, and often they require continuous treatment, monitoring, and heavy treatment. And the importance in monitoring patients admitted for status epilepticus continuously, if possible, lies in the fact that the sooner we break the vicious circle of seizures, the better it is in terms of neurological outcome. In fact, if seizures are not treated and resolved within minutes or even hours, they enter a state of refractoriness from which it is very difficult to exit. Furthermore, this refractory status is associated with increased neurometabolic derangement and in the long-term neuronal damage. It is therefore important to know if this population is having ongoing seizures and if the treatment is effective. And there is no other means to do so except then with EEG monitoring. But the risk of seizure is high also in other neurocritical care populations, not just patients with status epilepticus. And these are not necessarily admitted to ICU because of seizures. This includes all those patients with a degree of alteration of consciousness and or confirmed brain injury, whether this is traumatic, ischemic, hemorrhagic, infective, metabolic, etc. This should also be prioritized to receive some electroencephalographic monitoring to exclude or confirm seizures as the cause of their altered mental status. It is therefore important to suspect the presence of subclinical seizures, so not evident as convulsions, and therefore use EEG to exclude these in patients with prolonged post-ictal states after they had convulsions, with diminished alertness in the postoperative periods, after an acute neurological insult, such as a stroke, especially if they look worse than the deficit seen on neuroimaging. If they have impaired mentation, they have myoclonus or nystagmus, so some other peripheral symptoms. If they have episodic staring, aphasia, automatism, or perseveration, so some rhythmic features as well. If they have aphasia without a structural lesion on the neuroimaging studies. If they have acutely altered behavior without any other explanation, especially in the elderly population. Very often, these patients have subclinical seizures rather than convulsive phenotypes, either because of pharmacological agents they receive, such as paralytics, or because of the type of seizures themselves that tend to be subclinical. This bar chart of the observational findings from the literature summarizes the incidence of non-convulsive seizure and non-convulsive status epilepticus separated by the underlying etiology. And you can see that the vast majority of patients who present subclinical seizures are those who initially admitted with generalized convulsive status epilepticus, followed by infection, traumatic brain injury, intracerebral hemorrhage, and so on. Very often, clinicians request EEG for neurocritically ill patients who display unclear, persistent, and repetitive paroxysmal events, such as repetitive movements, shaking movements, rigoring, etc. It is important to exclude any epileptic etiology of these events by performing an electroencephalography study, as very often the semiology itself, so the phenotype of these movements, could be misleading towards either unnecessary treatment or a suboptimal dosage of the anti-epileptic drugs. However, an observational case series from more than 10 years ago now found that 75% of patients with abnormal repetitive movements were not having epileptic features, and they could have either peripheral disorders or dysregulated reflexias. In the 1/4 of the patients who showed an epileptic etiology, most were diagnosed with focal seizures or focal status epilepticus rather than generalized forms of seizures. It remains, therefore, very important to exclude the presence of seizures with EEG neuromonitoring in these patients to optimize treatment. There is an ongoing debate and no consensus at the moment regarding what has been defined the ictal-interictal continuum. This continuum encompasses a whole lot of electroencephalographic patterns that cannot be traditionally defined as seizures per se, but in some instances are heavily associated with the presence of seizures, either before or after the pattern has emerged. Additionally, in critically ill patients, some of these patterns correspond with the patterns described in the Salzburg criteria to define non-convulsive status epilepticus, making this definition impracticable for critically ill patients. It is important to note that there are no established criteria to define the ictal-interictal continuum as per ACNS terminology, and that very often it is easier to say what it is not in the continuum rather than what it is. Additionally, although there are no biological and clinical substrates to link some of these patterns to outcome, namely mortality and increased risk of seizures, as you can see from the graph, there are no clear-cut large prospective cohort data to demonstrate, or randomized clinical trial to demonstrate the effectiveness of any treatment of these patterns on outcomes. It remains important to monitor these patients, preferably with continuous monitoring, as the presence of some of these patterns could be highly associated with seizures, which have to be treated promptly instead. Until recently, using electroencephalography to monitor the evolution of ischemia in patients with subarachnoid hemorrhage has been cast aside as a research endeavor rather than a clinical tool. However, the accrual of evidence from the colleagues in North America mostly has provided convincing evidence that this monitoring is not only effective, but also time critical. This is an example of how a measure derived from the EEG, from the continuous EEG, the so-called alpha-delta ratio, so the ratio between the power of two different EEG rhythms, the alpha and the delta, could even precede the changes in both the clinical assessments, such as the decreased level of consciousness and some left motor symptoms, and the radiological finding, an infarct in the right internal capsule, by almost 24 hours in patients after subarachnoid hemorrhage. And this is another case to demonstrate the importance of the now available quantitative EEG trends in the new EEG softwares that are able to provide bedside. This is a Hunton-S4, a Fisher-4 subarachnoid hemorrhage. Initially, the quantitative EEG trends they remain stable with an alpha-delta ratio, which is the blue and red line, the second bar from the top. It remains very stable with an alpha-delta ratio that is close to what looks like being 0.8, and a relative alpha variability, which is the last few bars from the third to the bottom, the blue and red ones, which with a visual score of 4, which is called excellent. On day 4, which is roughly here, there was a global decrease in the alpha-delta ratio. You can see this downhill, this slope downhill. And there is also, you can see some changes in the relative alpha variability in different regions, but mostly in some, and we will see what. In particular, this patient had a TCD and a repeat CTA performed later during the day, day 4. So once this pattern has appeared, they show the evidence of diffuse cerebral ischemia and delayed cerebral ischemia, and they confirm radiographic vasospasm in both the anterior and middle cerebral arteries territories. Subsequently, on day 5, the patient had a clinical decline and the GCS dropped as well. And the diagnosis of DCI was made, but the EEG kind of preceded these events. Last but not least, in neurocritically ill patients, it is important to use EEG to monitor the response to treatment, whether this is intravenous anesthesia to control seizures in status epilepticus or deep sedation to control the cerebral metabolic rate in situation of increased intracranial pressure, such as traumatic brain injury. In any of these cases, it is useful to know we are achieving the electroencephalographic targets we set, whether this is burst suppression or seizure suppression or something else, and do not overshoot by increasing anti-epileptic drugs and sedatives unnecessarily. EEG in these situations is our end organ monitoring, and it allows us to titrate pharmacological strategies when the pharmacodynamics and pharmacokinetics are altered by critical illness, which often happens in our patients. Another proposed means of monitoring sedation in critically ill patients are processed EEG devices. However, in critically ill patients, it is still unclear what is the ideal EEG target to achieve for optimal sedation. Although many investigators have suggested the avoidance of burst suppression, there has not been high-level evidence to confirm its effectiveness on mortality and prevention of delirium. Therefore, the gold standard for sedation monitoring in patients with and without brain injury remains the clinical assessment. This opens the ongoing discussion about the possibility to develop more precise endpoints to titrate our drugs and optimize other treatments to prevent post-ICU delirium and agitation as well. It is now clear that the development of a single neuromonitoring target seems a little bit limited in the context of the complex pathophysiology of delirium disorders that we still partially understand. I have here summarized, in conclusion, the populations and respective indications for EEG monitoring in critically ill patients, and I have taken the liberty to add to the list monitoring of patients after cardiac arrest, although we have not specifically mentioned them today, as they're not usually admitted to neurocritical care. It is, however, worth noticing that the largest body of evidence for EEG monitoring prognostication lies within this population. I would like to thank you very much for the attention today.